Good afternoon to all, and welcome to the post-lunch session. So here we are discussing with the therapeutic communication, which is somewhat different from normal conversation between the persons. And you will come to know what are therapeutic communication and how to communicate with the psychiatric patient. And it will helpful in otherwise also, not only with the psychiatric patients. You can apply these techniques to your patients in other branches also. So aims and objectives of this lecture will be describing the goals of therapeutic communication, identifying therapeutic and non-therapeutic verbal communication skills, discuss non-verbal verbal communication skills such as facial expressions, body languages, eye movements, eye contacts, discussing boundaries in therapeutic communications, what should be done, to what extent will be discussed, distinguish between concrete and abstract messages, select an effective therapeutic response to the patient. Starting with the introduction, the communication has two parts. One is verbal communication, in which spoken words are communicated between the two or more persons. Non-verbal communications are facial expression, eye contact, body language. Tone of the voice is also the part of non-verbal communication. Speed and hesitations in speech, like grunts, groans, and distance from the listener is also important. So regarding the communication, therapeutic communication, there is a word called process, which denotes all non-verbal messages that the speaker uses to give meaning and context to the message. This process can be congruent or incongruent. For congruent message, for example, a patient says, I know I haven't been myself, I need help. So if the person is expressing the sad facial affect and a genuine and sincere tone voice which correlated with the words of the person, this means the process validates the content as being true. Otherwise, in incongruent message, the what the speaker says is not matching with the body language of the person or non-verbal messages of the person. Therapeutic communication is not the communication which we use in day-to-day life with each other and with the family members and all. The therapeutic communication is communication between the professional and the patient. And it focuses on the specific need of the uh, patient, not the extra information or otherwise information you have to process during the communication with the patient. Therapeutic communication, how it can help to accomplish the goal. The goals will be establish a therapeutic nurse-patient relationship, identifying the most important patient concern at the moment, assess the patient's perception of the problem, facilitate the patient's expression of emotions, teaching the self-care skill to the patient and the family members, recognizing the patient's need, what he needs at that time, implementation of interventions designed to address the patient's need or patient's problem, guiding the patient towards identifying a plan for problem that will be satisfying and socially acceptable. So communication is the means by which a therapeutic relationship is initiated, maintained, and terminated. It is not only initiated; it should be maintained and terminated at the appropriate time. Regarding the privacy and respecting boundaries of the therapeutic communication, privacy is desirable situation to communicate with the patient, but it is not always available. So patient should not be uh, have conversation in a too isolative state. The place and it cannot be the place which is too isolative, which and it can be the end of hall and a quiet corner of the day lobby, depending on the physical layout of the setting. So it is also pertinent to say that one have to need to evaluate whether interacting in the patient's room is therapeutic. For example, patient has difficulty maintaining boundary and have seductive behavior, then the isolated situation is not appropriate conducting the interview. A more formal setting would be desirable. The another term in the respecting boundaries and privacy is proxemics. Proxemics is derived from the word proximity, which means the closeness between the two people, and it is divided into four distinct zones, which are as follows: intimate zone, 0 to 8 inch between the people, and it is usually found in uh, the comfortable space for parents with young children and with the people who mutually desire personal contact and the people whispering. Invading in this intimate zone by anyone else is threatening or produce anxiety. So the intimate zone is for very close relationship between the two, and the personal zone is the distance is comfortable between family and friends who are talking. Social zone is 4 to 12 feet. The distance acceptable for communication is social, work and business setting. And the public zone, 12 to 25 feet. It is between a speaker and a large audience group or small groups. So these are the zones. In the proxemics, cultural aspect should also be kept in the mind. For example, in the case of Hispanics, Mediterranean, East Indian, Asian, and Middle Eastern are more comfortable with the less than 4 to 12 feet of space while talking. And conversely, and the of this background of European American and African American may feel uncomfortable if the patient from above background are dealing with. Conversely, the patient from these background may perceive the nurse as remote and indifferent because of the distance between the two. When the nurse must invade the intimate or personal zone, it should be also be asked for the permission from the patient. The invasion of this place should not be without the permission of patient. So he or she should ask permission in yes or no format, so the patient response is clear and cut. Another aspect is touch. Touching the patient can be comforting or supportive when it is welcome and permitted. And the nurse should observe the cues, whether the patient want it or not. And it may be declined by the patient. And the nurse may find touch supportive, while the patient may not. This situation may come across, and the patient may use too much touch. And again, the nurse must set appropriate boundaries. The patient is, I mean, want to come too close, appropriate boundaries should be made. So it's an comforting and therapeutic, and it's an invasion of intimate and personal space. Regarding the patients with mental disorder, some patients have difficulty understanding the concept of personal boundaries when the touch is appropriate or it is not appropriate. And the patient with history of abuse have had others touch them harmful or hurtful ways, usually without their consent, may get agitated. The person who has been abused physically or sexually may found the touch inappropriate and may get anxious, agitated, or may also get violent. Patient with paranoid delusions may interpret being touched as a threat and may attempt to protect. So a nurse verbally prepare the patient before starting a therapeutic touch. So it's very important to take the consent of the patient and we remain watchful for the situation and calculate the situation appropriately. So there are 5 types of touch has been defined. The functional and professional touch, which is used during the examination, physical examination of the patient, or procedures like minor and major surgical procedures. Social polite touch is used as greeting, such as handshake. When a gentle hand guides someone in the correct direction is also a special social polite touch. Friendship or warm touch involves hugging and uh, for example, throwing their arms around the shoulder of the person or the back slapping, and it is used to greet friends and relatives. Love intimacy touch involves tight hugs and kisses. Sexual arousal touch is used in sexual relationships. So in therapeutic communication, active listening and observation is also an important aspect. Active listening means the therapist is actively listening to the patient while keeping his mind free of the distractions. And active observation is watching the patient's non-verbal actions as the patient communicates. So it is a misconception that uh, while one is interviewing the patient, they may think of the further question to be asked and distracted by the questions which are running in their mind to be asked further when the patient stops. And the patient will find that the therapist is not listening properly, and the therapist may conclude that the patient is repeating their concern too much. So keep your mind free of the distractions while actively listening and observe the patient's non-verbal cues. If it is not complied, this can result into the nurse do not understand the patient's concern and the conversation is vague, superficial, and frustrating. A therapist may complain that the patient is repeating things and not taking responsibility for getting better. The nurse does not get details and works from his or her assumption, and the nurse will not be able to grasp the factual position what is being going in the mind of the patient. They may get a wrong assumptions. So active listening and active observation helps in recognizing the issue that is most important to the patient. Know what further question to ask the patient. Despite repeating the questions in the mind beforehand, one should listen to the patient properly and then completing the conversation, they can frame another question which is in the line of the communication and appropriate. So one can use additional therapeutic communication techniques to guide the patient to describe his or perception fully. So one can intervene during the conversation to take the conversation further to clarify or use additional therapeutic techniques. One can understand the patient's perception of issue instead of jumping to the conclusion. So while keeping track on the conversation, one will be able to make a rational conclusion uh, and not jumping to the conclusion on other way. Interpret and respond to the message objectively. So these are the benefit and which helps in a therapeutic relationship. Verbal communication skills. What skills one can use to communicate and to establish a therapeutic relationship? Use words that are as clear as possible. For the patient who is anxious and does not have that much good cognitive processing, so the concrete message are important rather than the abstract message. So concrete message that the words are explicit and need no interpretation. While in abstract questioning or abstract communication, one do not get the meaning of the question and one have to rephrase the question again and which may also alter the process of communication. Abstract messages are unclear pattern of words that often contain figure of speech that are difficult to interpret, and the listener has to interpret what the speaker is asking. For example, how did you get there has been asked, and a person with anxiety disorder may interpret as where am I, and also may interpret as the ambulance brought me here. So one may be asking what symptoms made you to get here. So it is an unclear question. How did you get here? So numerous responses can be there, and patient may not understand what question has been asked. The following are the example of abstract and concrete message. The first one is abstract messages get the stuff from him. That can be reframed as John will be home today at 5 p.m. and you can pick up your clothes at that time. So the second concrete question has addressed to whom with the person has to communicate to the Mr. John and he will be at home He will be at home at 5 p.m. and he has to pick up the clothes. So this is a clear-cut question rather than the first one. The second example is your clinical performance has to improve. The concrete question will be to administer medications tomorrow. You will have to be able to calculate doses correctly by the end of the today's class. So there is a clear-cut task for the student to administer medication tomorrow, and one have to perform to calculate the dose correctly. And by the end of today's class, this is the time frame given to the to complete the task. So this is a clear-cut question, and it has concrete meaning. Now, using the therapeutic communication techniques, or many therapeutic communication techniques are there, and the choice of technique depends on the intent of the interaction, for what the interaction is being done, and the patient's ability to communicate verbally. If a certain technique is used for a certain situation, or appropriately can be used by the therapist. Techniques such as exploring, focusing, restating, reflecting, we will go through all these type of therapeutic techniques one by one. And overall, one have to select the techniques that facilitate the interaction and enhance communication between the patient and therapist. So these techniques which are used in therapeutic communication, one is accepting, which is indicating the reception. The question may the response may be yes, or I follow what you said, or nodding of the head. So this is accepting the response of the patient. Next is broad openings. Broad openings mean allowing the patient to take the initiative. The question will be an open-ended question, not a specific question. Like, is there something you had like to talk about? So this is an open-ended question. Patient can come up with any response regarding what he want to talk. So broad opening are helpful to explore the concern of the patient or sign and symptoms. Consensual validation, searching for the mutual understanding, like tell me whether my understanding of it agrees with your statement or not. So this is taking as a validation of what the patient has said. Encouraging comparison, like have you heard similar experiences? In this, the therapist asking that similarities and differences. So if the similar experiences have experienced by the patient, so this can be framed on the timeline to uh, make the repetition of the incidences or to make the certain diagnosis like panic disorder, in which the multiple episodes of panic attacks are required. Encouraging description of perception, what he or she perceives. So in this more description is sought from the person, like tell me when you feel anxious or what is happening to understand the whole situation. Encouraging expression to appraise the quality of his or her experience. So, like what are your feelings in regard to such and such, and for such and such situation, it is this is encouraging the expression of the person. Does this contribute to your distress? Okay, this is also encouraging the expression of the patient in a detailed manner. Exploring is delving further into subject or an idea. Tell me more about that. So exploring the thing more and more into the depth. Focusing is concentrating on a single point. So this point seems worth looking at more closely. If someone wants to focus on a certain point to explore more, to understand more, so one can uh, use the words like that, which after which the person will become more focusing on a certain point of concern. Formulating a plan of action, uh, like behavior likely to be appropriate in a future situation. So the question that can be, what could you do to let your anger out harmlessly? So it is formulating a plan of action, what the person can uh, plan for future while discussing their anger outburst in the current situations. Journal leads giving encouragement to the continue, like go on and then tell me about. So these are the journal leads. So patient will further talk about his problems or his concerns to the in a more details. Giving information, making available the fact, like my name is this and visiting hours are these. So this is the information given by the therapist. It's a general information, the availability of the person from which time to which time, and the name of the therapist. The next one is giving recognition. It is acknowledging and indicating awareness. I notice that you have combed your hair. This is giving recognition to the patient, or the patient may be addressed by the name, and this will be a good thing for therapeutic communication skills. Making observations like verbalizing what the nurse perceives. You appear tense. The therapist have seen that the person is tense, but he or she is not expressing his uh, anxiety or their stressor. So one can make observation and make the prompt like the person will come up with uh, all of his sufferings. Offering selves, making oneself available. So the sentence may be, I will sit with you a while. I will stay here with you. So offering the availability of self to the patients. Placing events in time or sequence. Like what is this? Was this before or after a certain event, or when did this happen? ये कब हुआ? Presenting reality, offering for consideration that which is real. So like I see no one else in the room. If the person is having visual hallucination and he is expressing that someone is standing there, or I can visualize the such a such thing, so one can present the reality to the person that I see no one else in the room. Reflecting is directing patient's action, thoughts, and feelings back to the patient. Like when patient said, "Do you think I should tell this to the doctor?" So a nurse can ask or ask like, "Do you think you should?" Yes. So this is a reflection of his own question to the patient himself. Restating is repeating the main idea expressed. Like patient said, I can't sleep, I stay awake all the night. So one can respond like, you have difficulty in sleeping. So one can explore the uh, insomnia or problem with the normal sleep. Seeking information, seeking to make clear. I am not sure that I follow. Have I heard you correctly? So seeking information, if the therapist is not able to understand on the first instance, then he or she can seek the information from the patient more. Silence in verbal communication skill is also important. It's the absence of verbal communication when the therapist says nothing and but continues to maintain eye contact and conveys the interest. Suggesting collaboration, like offering to share, to strive, and to work for patient benefit. For example, I am not sure that I follow. Have I heard you correctly? These are suggestions which seeks the suggesting collaborations. Summarizing means organizing and summing up the whole conversation. So, like during the past hour, you and I have discussed this, that, this. You can summarize as you have given summary in the your seminar or in your talk or in your lecture in the last. You can summarize all the things in the end of the session. Translating into feelings, uh, seeking to verbalize patient's feelings. For example, the patient had said, I am dead. So one can ask, are you suggesting that you feel lifeless? So this the feeling of lifelessness is translated from the words of the patient. Verbalizing the implied, voicing what the patient has hinted at or suggested. For example, patient can say like, I can't talk to you or anyone. It's a waste of time. So therapist can interpret as, do you feel that no one understands? So patient uh, express that it is a waste of time to talk to anyone. So it can be the feeling like the person or patient is uh, perceives as no one understanding his feeling or what he want to say. Voicing doubt, expressing uncertainty about the reality of the patient's perception. Like, isn't that unusual? Or one can express as really That's hard to believe. So doubt is has to be cleared, and there is a minimal chance of considering assumptions while communicating with the patient. Assumptions are not required, or you can say is prohibited in the therapeutic communication. There should be no doubt in the mind regarding the concern of the patient. So there are do's for verbal communication skills. Then there are also the don'ts which should not be used in the therapeutic communication. It should be avoided, like advising the patient, telling the patient what to do. This should be avoided, and this is not. One should not impose their own ideas onto the patient. Agreeing, indicating accord with the patient, like that is right, I agree. So your agreement and disagreement should not be imposed on the patient. You should remain somewhat neutral to the therapeutic communication. Belittling feelings expressed. So one cannot belittle the feelings. matlab, They cannot. The therapist cannot should give the appropriate weightage to the feelings of the patient. If the patient is sad, so this should not be uh, taken as a exaggerated response. The depressed patient will be depressed and have sad mood most of the time, and it will be pervasive. So do not belittle the feelings which is expressed by the patient. Challenging is demanding proof from the patient. Do not demand proof from the patient, like if you are dead, why your heart is beating. So do not challenge the patient. Do not defend yourself. Do not defend yourself like this hospital has a fine reputation. You cannot say like this, or I am sure your doctor has your best interest in mind. Defending what the patient has criticized implies that he or she has no right to express impression, opinion, or feeling. So patient may become guarded. He won't come out with his actual ideas. The person may uh, refrain to talk with the therapist. So do not defend unnecessary in the front of the patient. Disagreeing, opposing the patient's idea. I do not believe that, and disagreeing implies that the patient is wrong, and consequently the patient feels defensive about his or her point of view or ideas. Disapproving means denouncing the patient's behavior or ideas. That is bad. It would rather you won't. So do not communicate in this manner. The disapproval implies that the nurse has the right to pass judgment on the patient's thought or action. So do not try to pass your own judgment. It should be remain neutral. It further implies that the patient is expected to please the nurse. So patient can further try to please the therapist. Giving approval, sanctioning the patient's behavior or ideas. Like that's good. I am glad that. So do not give approval the patient's words. Saying what the patient thinks or feel is good implies that the opposite is bad. So to keep the situation neutral, you should not give approval. What is wrong and what is right. Giving literal responses. Responding to a figurative comment as thought it were a statement of fact. Like the patient said that they are looking in my head with a television camera. Is this situation related to the uh, delusional idea? And nurse should not respond like try not to watch the television or try not to watch the particular channel. Because the ideas, the delusional belief is ego-syntonic ideas. This is real for the patient. So do not confront with those ideas and do not give literal responses. Indicating the existence of an external source. So by so attributing the source of thought, feeling, and behavior to others or to outside influences. Like what makes you say that? What made you do that? Who told you that you were a prophet? So do not indicate the existence of external source. So nurse can ask like what happened. So it will be a open-ended question which will explore more of his mind. What events led you to draw such a conclusion? So if it will be also open-ended question, can help to understand the patient's thinking. Interpreting means asking to make conscious that which is unconscious, telling the patient the meaning of his experience. What what you really mean is unconscious. You are saying the patient's thought and feeling are his or her own and not to be interpreted by the nurse for hidden meaning. So one should not interpret for the what the patient is saying. Introducing an unrelated topic. If the person is talking about certain topic, do not ask for or to deviate it from the current situation to an unrelated topic. Making stereotype comments like it's for your own good, keep your chin up, means offering meaningless glitches or trite comments. Probing is persistent questioning of the patient. Tell me your psychiatric history. It, the thing should not be used while talking with the patient. Pushing and probing by the nurse will not encourage the patient to talk. Too much probing should not be there. Reassuring that I won't worry about that, everything will be all right. So give the factual situation and talk about the facts. Do not reassure the patient, which will completely devalue the patient's feeling. Rejecting means refusing to consider or show contempt for the patient's ideas or behavior. Let's not discuss or don't want to hear about. This may lead to the patient may feel personally rejected along with his ideas. Requesting an explanation. Why do you think that? Why do you feel that? So requesting explanation, the question starting is why is by and large contraindicated in therapeutic communication. It is not a good idea to come with the question with why. Using denial, refusing to admit that problem exists, and denial should not be used unnecessarily. Testing the patient degree of insight should not be there. Like, do you still have the idea that do not directly test the uh, delusional belief of the patient. So after the technique, how to interpreting the signals and cues. To understand what the patient means, the nurse watches and listens carefully for the cues. So active listening and active observation should be there. Cues may be verbal or non-verbal messages that signal keywords, issues for the patient. So finding the cues is a function of active listening, and cues can be buried in what a patient says, can be acted out in the process of communication. So often cue words introduced by the patient can help the therapist to know what to ask next and how to respond to the patient. So this builds the therapeutic relationship between the patient and the therapist, and understanding these cues can relieve pressure on the student who are worried and anxious about what question to ask next. So you have to understand about the signals and cues which the patient will express, and you have to take the lead of that cue to communicate further with the patient. So how to interpret? These are the examples. Like if the patient said, "I had a boyfriend when I was younger," so the therapist can ask, "You had a boyfriend." This is the reflecting of the question of the patient's self. Tell me about you and your boyfriend. This is encouraging the description of the relationship. And how old were you when you had this boyfriend? This placing events in the time or in the sequence. So these are the technique used in this conversation. In the theme of sadness, if the patient says, like, oh, he said something, and the face of the patient is sad, eye looks teary, voice is low with little inflection. So one can ask, you seem sad today, Mr. Venezia. The recognition is there. The patient has been addressed by the name and verbalizing the feeling. So the patient gesture or non-verbal cues has been translated into the sentence that you seem sad today. Further, yes, it is the anniversary of my husband's death. So one can respond like, how long ago did your husband die? So the nurse can use the other cues, and this is the confirming the timeline of the events. Or one can respond like, tell me about your husband's death. This is open-ended question to explore the situation at that time. Theme of loss of control. The patient may respond like, I had a fender bender this morning. I am okay. I lost my wallet and I have to go to the bank to cover a check. I wrote that last night. I can't get in contact with my husband at work. I don't know where to. So these are the somewhat like circumstantial. In this one paragraph, many events have been discussed. So one can respond like, I sense you feel out of the control. So translating the situation into the feelings that you are feeling out of control. In interpreting signals, there are signals which may be overt or covert. Overt means which can be interpreted very easily, and the direct cues for the conversation, and some some uh, some expressions are covert cues which has a hidden meaning. Like covert cues are vague, and for example, nothing can help me. This is a vague or indirect message. One can clarify from the patient what is the thought behind this. The patient may have an intent to self-harm or may uh, plan for the suicide. So it is very important to pick up the covert cues. So because most suicidal patients are ambivalent, so it is important to pick up the cues and interpret and to act appropriately. Theme of hopelessness and suicidal ideations. Patient may respond like, life is hard. I want it to be done. There is no rest. Sleep is good, and sleep forever. So one can interpret and this covert cue that I hear you saying things seem hopeless. I wonder if you are planning to kill yourself. So verbalizing the implied. So what the patient is verbalized, what can be the implication of that verbalization has been put into the words. Other thing which may be covert cues, may be metaphors, proverbs, and glitches. The metaphor you can say it's in Hindi it's a rupak or maybe a pratik. The pratik, the things which is said by the patient in a metaphor way, uh, maybe a hidden meaning which should be explored. Like patient may say, "My son's bedroom looks like a bomb went off." So this can be interpreted as you are saying your son is not very neat. So this is not a final conclusion. This is an exploration, verbalizing the implied. This is a technique to find out what is behind the sentence of the patient, which has been said in the interview. So one can respond like my mind is like mashed potatoes. So one can interpret as I sense you find it difficult to put thoughts together, translating into feelings. And further interview will go on and to explore the situation more and more. Proverbs are known as muhavras, like patient may say people who live in the glass houses shouldn't throw stones on the others. So this can be interpreted as who do you believe is criticizing you, but actually has similar problems, encouraging the description of perception, what the patient uh, perceive while talking like this proverbs. What is the hidden meaning behind this? What situation the person is thinking about? So this should be explored by encouraging the description. So non-verbal communication, as I've said earlier also, these are the facial expression, eye contact, space, time, boundaries, and body movements. Less likely able to control the non-verbal communication by the patient. So the patient can control somewhat the words while speaking, but gestures are not easily controllable. So it is important to validate the meaning of non-verbal behavior. The non-verbal behavior should not be accept as such should be explored and should be clarified. So here you can see the facial expressions in our culture in Kathakali. The various facial expressions are expressed by the dancer. Maybe it's of love, comic, peace, wonder, maybe terrible, maybe odious, maybe furious, pathetic, and maybe heroic in the last. So again, starting with the facial expressions may be expressive, impassive, or confusing. Expressive face means what the person is having in the mind, the thought in the mind, which is matching with the facial expression of the person. Impassive face is a frozen into a emotionless deadpan means mask-like faces. The person do not express much of the emotions by facial expression, which is not in congruence with the thoughts in his mind. Confusing facial expression may be called as incongruent effect, in which the person has a different kind of thought in the mind and the expression is entirely different from the thought. For example, the person is sad, maybe laughing. So facial expression often can affect the listener's response. For example, strong emotional facial expression with the thought in the mind can be taken as a actual facial expression. For example, by appearing perplexed and confused, a patient can manipulate the nurse into staying longer than scheduled. So the patient can manipulate his expression if he wants the therapist to be there for a longer time. So facial expressions such as happy, sad, and all the facial expression have a same meaning across the culture, but it is very important to explore and identify and to be related with the current situation, whether it is congruent or incongruent with the patient's thought in the mind and his facial expressions. Frowning, smiles, puzzlement, relief, fear, surprise, and anger are common facial communication skills. Looking away, not meeting the speaker's eye, and yawning indicate the listener is disinterested, lying, and bored. So, check the congruency with the content of the thought. Body language is gesture, posture, movements, and body position. Closed body position, such as crossed legs and arms folded across the chest, indicating that the interaction might threaten the listener who is defensive or non-accepting. So, for acquiring a best body languages, to sit facing with the patient, both feet on the floor and knees should be parallel, and hands at the side of the body on the armchair, and legs are crossed, uncrossed, or crossed only at the lower level at the ankle. And this open posture demonstrates unconditional positive regard, trust, care, and acceptance for the patient to communicate with the therapist. So, nurse can indicate interested in and acceptance of the patient by facing and slightly leaning forward. So this body language is more accepting and encourage the free conversation between the therapist and the patient. Adding to it, hand gestures add meaning to the content of the therapist. A slight, for example, a slight lift of hand from the arm of chair can strengthen the meaning of word. And like holding both hands with palm up while shrugging the shoulder often means I don't. The positioning of the therapist and patient in relation to each other is also important. The best sitting setting is sitting beside or across from the patient can put the patient at ease. Do not sit at do not sit directly facing to the patient. Sit at somewhat angle of the 45 degrees. So one cannot be directly uh, see the patient, or the patient will be comfortable to the situation. In a situation while sitting behind a desk may uh, create a physical barrier which may decrease the patient willingness to open up and communicate freely. So desk is creating somewhat a barrier to the therapeutic communication. So while setting the sitting position, one should take in account the boundaries, and accordingly, according to the situation, the physical boundaries should be applied while interviewing. Vocal cues also give the messages like volume of the speech, tone of the speech, pitch of the speech, emphasis on the words, speed of the speech, and pauses also gives the message while therapeutic communication. The loudness of voice can indicate anger, fear, happiness, or deafness. The tone can indicate whether the mood is relaxed, is agitated, or bored. Pitch may be interpreted as indicating the importance. The pitch varies from shrill and high to low and threatening, which is also indicative of some thoughts behind the mind. Emphasizing the certain word can highlight the situation on which the person wants to talk. Speed and pauses are also important. Pauses means the silence, which further facilitate the interview. So high-pitched voice is indicative of anxiety. The use of extraneous words with long, tedious description are called circumstantiality, or it can indicate the patient is confused about what is important or is a poor historian. Slow, hesitant response can indicate the person is depressed. So it is important for a therapist to validate these nonverbal indicators rather than to assume. So these indicators, whether vocal, whether it is related to eye contact or body posture, every time it has to be clarified and validated. So eye contact can gives the message of humor, interest, puzzlement, hatred, happiness, sadness, horror, warning, and pleading. So eye contact should not be prolonged while the conversation, and do not stare at the patient. And do not keep the eye contact for a long time. Do not stare, do not keep the eye contact in a derogatory or threatening manner. Silence is also important. Silence may indicate that the psychopathology, or it may act as it may be used for a good therapeutic communication. So, for example, for psychopathology, the patient may be depressed or struggling to find the energy to talk. So, this also this silence also indicative of depressed psychopathology. Sometimes it indicates the patient is thoughtfully considering the question before responding. He is thinking of the question or analyzing the question to respond. And sometimes it indicates the patient is not paying attention or lost in his or own thoughts. So it is important to allow the patient to give sufficient time to respond. And so one cannot jump to the conclusion. And in this silence period, one should not jump to the another question. Give the sufficient time to the patient to respond. So understanding the meaning of communication. For example, if someone had said, I am so tired that I just can't go on, the patient may be experiencing the fatigue of the depressive symptoms, or may mean the patient wishes to die. So it should be clarified with the patient what the meaning the patient is having. For example, an outwardly appearing, dominating appearing man often manipulate and criticize others in reality may have low self-esteem. So for, for the example, insecurity and low self-esteem may lead to jealousy and mistrust of the others, and this may lead to attempts to feel more important, strong by the dominating or criticizing them. So criticizing and dominating behavior may have underlying insecurity and low self-esteem. Understanding the context, I am going to kill you. This may be said by the patient. This may be interpreted as anger during an argument. This may be actual violent behavior of the patient, or the person may planning a surprise party for another person. So this can be hidden thought behind this sentence should be explored. Further, like I collapsed, This may the person has fainted or felt weak and had to sit down. The another one can interpret as she could mean she was tired and went to bed. To clarify these terms, one can ask, what do you mean by the collapsed, or describe where you were and what you were doing when collapsed. So seeking clarification, placing events in the time and sequence is exemplified in this questions. Understanding the spirituality. While making a therapeutic relationship with the therapeutic communication, spirituality of the person should also kept in the mind. Spirituality means a patient's own belief about the life, health, illness, death, and one's relationship to the universe. It is different from the religion. Religion is an organized system of belief which is imposed by the religious bodies. So spirituality and religion often provide comfort and hope to the people and can greatly affect the person's health and healthcare practices. So it should not be ignored or devalued. For a professional, profession must first assess his or own spiritual and religious beliefs. Religion and spirituality are highly subjective and can be vastly different among people, and it's between the therapist and the patient also. So a therapist must remain objective and non-judgmental. He or she should remain neutral about his own spirituality or own religious values. And the patient should not be ignored or ridiculed because of his or her beliefs and values which differ from those of the therapist. So in this matter, one should keep themselves neutral. Cultural considerations should also kept in the mind for behaviors, values, beliefs, and custom. Each culture has its own rule governing verbal and non-verbal communication. For example, in West culture, the handshake is a non-verbal greeting. For women, a polite hello is an accepting term of greeting. So various culture has various ways of communication. So one should be aware of the situation and respect the cultural consideration of the person. So what should be there in a therapeutic communication session is in the session of communication, therapeutic communication, one should establish the rapport with the patient, actively listen to the patient, and should gain an in-depth understanding what the conversation is going on. Explore the patient's thoughts and feelings, facilitate patient's expression of thoughts and feelings, guide the patient in developing new skill and to attain a problem-solving technique, promote the patient's evaluation of solutions. For example, therapist may say, hello, Mr. Y, my name is X. I will be your nurse today. I am here from this to this time. Right now, I have a few minutes. So in this communication, the techniques which are acquired are giving recognition by addressing the name of the patient, introducing cell, and setting the limit of the contact from 7 a.m. to 3:30 p.m. One should acquire a non-directive role in which it is often that the patient who identifies the problem, not the therapist. Therapist should remain neutral in identifying the problem. The therapist uses active listening skills. The patient identifies the goal and the information gathering about this topic focuses on the patient. So nurse acts as a guide in the conversation, not the uh, leading or active person. The therapeutic communication centers on achieving the goal within the time limits of the conversation. So time limit should also be there. It is not like they have interacted for a very short period of time and conclusion had been made, or the session is going for a very prolonged time. The example of conversation of a non-directive role, like patient said, I am so upset about my family. So response are you are upset, reflecting the patient's own word. Patient may say, yes, I am. I can't sleep. My appetite is poor. I just don't know what to do. So nurse can say, go on using a general lead. So a person will come up with more and more sign and symptoms and concerns. So other kind of accepting, encouraging expression should also be used and can be used appropriate to the situation. Directive role can also be taken when the patient is in crisis or the patient is in the danger situation, like the patient is having suicidal ideations. So a therapist can make observation. For example, I see you sitting here in the corner of the room away from the everyone else. So the further responses, what's the point of what? So further responses, you sound hopeless. So exploring the uh, thinking behind the this behavior of the person is sitting corner in the room away from the everyone else. So person may have ideas of suicide in his mind. So it should be actively or directly should be explored and probed. So how to phrase question? The question should be open-ended. So more information should be gathered. Different type of question can be used based on the information. So if the person do not understand the one question can be rephrased with the meaningful conveyance. Use active listening. So for example, what do you feel about that test can be rather used as how well do you think you did on the test. Second one is a more important, more appropriate question to be asked. Other examples are, what did you think about your daughter's role in her automobile accident? The patient may respond, I believe she is just not careful driver. She drives too fast. So this gives this impression. This can be rephrased as, how did you feel when you heard about your daughter's automobile accident? The patient may respond appropriately like relief that neither she nor anyone else was injured. Asking clarification is important. Ask clarified, do not keep the confusion in your mind and do not assume from your own side what the patient is said and do not jump to a wrong conclusions. Guiding the patient in problem solving and empowering the patient to change. In some situation, it is important to try to get the problem solving techniques to the patient. The therapist should help the patient to explore the possibilities and do not impose their own ideas and their own ideas or they are saying like you have to do this, you can do this. This should not be done. This should be explored by the patient himself, and nurse should uh, act, acts as a guide. So it involves identifying the problem, brainstorming exercise to explore all the possible situations, select the best alternative, implement the selected alternative, evaluate the situation again. If the results are dissatisfied, then this cycle can be taken into account again from the step one. Assertive communication is important in when there is a conflict between the family members or conflict between the peoples to solve the problem. So assertive communication can help the person deal with issues with the co-workers, family members, friend, spouse, with whom they are having uh, bad communication. So this assertive communication can be used by the persons like there may be aggressive type of communication between them. There may be passive aggressive communication. Like aggression is shown, but in a passive way, from a parallel way. The person is harmed or the action of aggression is taken. Passive means, for example, she always late. I had to tell her what she missed. I have so much work for my own to do. A nurse doesn't say anything at that time, but later tells the coworker this thing. This is a passive kind of communication. Assertive communication, like after report, one can say, when you are late, report is disrupted, and I don't like having to repeat information that was already discussed. So this is a direct confrontation. This is an assertive type of communication, which may lead to a poor relationship with each other. So in conclusion, is that the all the parties should be given a chance to express themselves. They should there should be a polite and good confrontation between them, and one can act as a moderator or guide to resolve this conflict. So the person may feel good about the expressing the feelings within them, and this communication can help the person say no politely but firmly if they are not able to do it previously. Community-based care are also important for communication, and again, all the rules are applied in community-based care. Also, the thing is important is when the therapist enters the home of a patient, the therapist is the outsider and must learn to negotiate the cultural context, spiritual context, and religious context, and not judging them according to their own cultural context and their beliefs. Self-awareness issue. The therapist should be self-aware regarding the learning the communication skills, and this is an ongoing process. One should keep practicing it to improve themselves, and they should acknowledge their shortcomings and deficit with their colleagues and seniors and supervisor, and make them more expertise in communicating in therapeutic manner. So, in summary, communication is the process people use to exchange information through verbal and non-verbal message. Therapeutic communication is different from the normal communication. Goal should be to establish a therapeutic relationship between them, and the crucial components are to keep in mind the privacy and respecting the boundaries, self-disclosure, use of touch, active listening, and observation of skills. It should be concrete rather than vague or abstract. Non-verbal communication are body language and other aspects. Understanding the context is most important to the accuracy of the message. Context should be explored. It should not be assumption. Spirituality and religion to be taken into the account. Cultural differences are there. They should be also taken into account. Guiding the patient for problem solving in this assertive communication is important. Therapeutic communication techniques and skills are essential for successful management of the patient in the community. And the greater the therapist understanding of his her own feelings and responses, the better the nurse can communicate and understand others. So these points are all important in therapeutic communication. Thanks for patient listening. And if any question or queries are there, one can ask.